Pacemakers are obviously the box that sits around the hollow of the shoulder these days, and there are ports on the pacemaker that we can insert these silicone covered very flexible wires. They're made of various things, not just silicone, sometimes polyurethane, various other things. And we can either have a tiny little screw at the end of the lead, as you see here, or you can have some tines at the end of a lead. We call a screw active and some tines passive fixation as a way of getting it to stick in the right place. And we tend to put wires with screws in by and large. So that tiny little screw, about 1 or 2 millimeters long, screws into the heart. So as always, please comment or unmute or put comments in the chat. It's great to have some interaction go on with these presentations. I'm going to start with sort of an introduction with a little bit of history of pacemakers while other people are joining. They're missing a treat because the history of pacemakers is really fascinating. But I'll also spend a little bit of time in the first few minutes talking about the different types of pacemaker and how we call them different things, if you've wondered what the difference between a single and a dual chamber pacemaker is. And about how they work. And then the bulk of the presentation will be of various case studies and what might make you think of different types of pacemakers in those patients. So the history of pacemakers started properly in 1958. Actually, there was an external pacemaker going back even, I think, to the 1930s, but it was obviously no good if you had to have an enormous machine that you were next to keep your heart paced. So before 1958, patients died of heart block and of asystole, and it's amazing how many patients get pacemakers. It was no infrequent thing back then. To die of what is now a completely treatable condition. And actually pacemakers are one of the most economically bang for buck. The cost of a pacemaker is about £1,000, and if that then keeps the patient alive in good health for years that they wouldn't have had, it's incredibly a good way of spending our healthcare resources. But the very first pacemaker went in all those years ago. And the interesting thing about this one is that it charged through induction, like the latest Samsung and iPhones and all the latest tech. It charged wirelessly through the skin. The battery only lasted for a few days, so the patient had to constantly charge the thing up. And it inevitably recharged batteries don't last very long, so the thing wore out fairly soon and needed to be replaced. But the patient survived because they got the pacemaker. It was a young patient, as inevitably the first things always go to fit young people who have only got one problem, and he survived and went on to show up at conference circuit for many years. Pacemakers come in all sorts of different shapes and sizes, and there's a 10p here for size comparison. Actually, these are all old models, and they've changed a bit, but not a huge amount. And the fact that different companies make such different size and shapes devices is worth noting. We have single chamber devices which have got one port for a lead. And we have dual chamber devices, which is what all of these are, where there are 2 ports for the lead to go in. We can also inject monitoring devices. These don't work as pacemakers. We used to put this sort of a size device. It was about 1 centimeter wide, about 3 centimeters long. We used to put that in a small surgical procedure around the delta pectoral groove, but nowadays the reveal link is only about 2 or 3 millimeters wide and is literally injectable. Makes it very easy to put these things in, so they're great for monitoring patients who have infrequent symptoms. There's also one injectable pacemaker on the market, which is the Medtronic Micra. There was a St. Jude version of this that actually was withdrawn because of some negative outcomes. And it would be great to have another company's device on the market, because it's always good when there's some competition in a field. But this device uses these tines to grip onto the heart and is completely inside the patient with no lead. The idea being that that reduces the risk of complications. A lot of the complications come from the leads. The battery life of this is about 10 years, so it's a nifty little device. We also have biventricular pacemakers, and you can see that this lead is a very different shape from the other two. This hooks into place. It doesn't have a screw on the end, and that goes inside the coronary sinus. I'll talk more about that later. And there are 4 different poles on this example. There are also bipolar, just 2-pole leads like these with that bipolar 2 poles. That we use for pacing the left ventricle. And we also have defibrillators. Box is a bit thicker because it has to have a much bigger battery in. It has to be able to deliver a very big shock rapidly, and it also has to have large capacitors to store that energy and release it very rapidly. So ICD is about 1/3 electronics, 1/3 battery, 1/3 capacitors inside this thing. And the ICD lead looks very different again from these ones. So you can see one end of the ICD lead looks a bit like this, and then the other end has got a metal coil on it, and it delivers the shock between the coil here and the pacemaker pulse generator at the shoulder area. And you can always tell a patient has an ICD on the basis of them having this thick coil on the lead. I'll show you that later on, so that you can always tell if a patient has an ICD from an X-ray. How many pacemaker implants a year? This is a bit old. It's 2011, and you know, the numbers of pacemakers are increasing as the populations get more elderly and frail. But if you look at Europe as an average of 938 units per million, UK was way down at 677 pacemakers per million. Germany is much higher. This is obviously just Europe. And you can see the numbers have been increasing year on year. I don't know what effect COVID has had on that. That might be interesting to look at. So we put lots and lots of these devices in. But what is it with this single, dual? What do we mean when we say DDR or whatever numbers and letters we come up with? Well, we have 4 boxes that we use to call pacemakers different things. And the first box refers to the chamber of the heart that the pacemaker is able to pace. So if it's an A, it means that there is just a lead going to the atrium. So it's an atrial pacemaker if the first letter is an A. And that would be a single chamber pacemaker because it's only pacing the atrium. If it only paces the ventricle, it would be a V. And if it paces both the atrium and the ventricle, it becomes a D for dual chamber pacemaker. So atrial or ventricular pacemaker is a single chamber device, and actually a pacemaker will quite happily be either an atrial pacemaker or a ventricular pacemaker if it's a single chamber device. The second letter along refers to what it does. So, or rather what chamber it listens to, and the third chamber refers to what it does in response to that. So A means it listens to A, and if it sees a signal in A, in the atrium, then it doesn't pace the atrium, which is generally what you want. V and an I means that it listens to the ventricle, and if it sees a ventricular stimulus, it inhibits the pacemaker. More often, you get a D in there because you want it to both stimulate the ventricle if it doesn't see anything and not stimulate the ventricle if it doesn't see anything. So you don't want it just to be inhibited. And then the last letter is an optional letter, and it's an R for variable rate or rate responsive, and it can use vibration. So if you shake a pacemaker around and then put it in the pacemaker, they get a tachycardia because they've had their pacemaker shaken around before you put it in. Sometimes we do that inadvertently. It very rapidly settles down. It can also do things like sense how fast a patient's breathing by looking at thoracic impedance. So pacemakers can do various clever things to work out how fast the heart needs to go if they can't rely on the natural pacemaker, either because you've got sinus node disease or you might be in atrial fibrillation, say. So normally it might just set it up listening to how fast the atrium wants to go, but you might have to set it so that it can respond. And that's where the fourth letter comes in. So that's why we call pacemakers AIR or VVIR or DDD. Don't worry if that didn't make too much sense, but hopefully you can see the difference between a single chamber and a dual chamber pacemaker. There's also, we sometimes, I think I'm probably getting too technical here, but we can also put O in those boxes to say that we ignore what's going on. And the very first pacemakers that weren't clever at all they could do was pace the heart. And so they were VOO devices that went at a fixed rate, couldn't speed up. And so if you looked at a tracing of their heart, you might see that their heart's pacing at a steady rate, ignoring the underlying rhythm. And the danger there is that you could end up pacing on top of the T wave. And that's a vulnerable period. If a pacing spike lands on a T wave, that can put patient into VTVF. So that's to be avoided in general if there's an underlying heart rhythm. But sometimes if the lead is not working properly and it can't sense the heart, it can't see what's going on in the heart, or it gets noise that's inappropriately suppressing its function, we have to set it up in unusual ways. You can even set it up DOO, where again it's pacing the atrium and it's pacing the ventricle, even if intrinsic rhythm is coming through, which is potentially dangerous. So that's what I wanted to say about pacemakers and the way they work. I'm now going to talk about the indications for pacemakers. And I'm basing this on the 2021 ESC guidelines. I haven't updated every slide from I had some from the 2013 guidelines, but pacemakers haven't changed that much. And I've looked through the guidelines and I don't think anything has changed. I'll be giving you different classes of evidence, and I'm sure you'll have seen these sorts of slides before, but it's really useful to be aware that different indication strengths and different levels of evidence. And these are totally different concepts. So you can have a class 1C, so it's very, very strongly recommended, but there's no evidence, no good evidence for it. So there are some things that we're never going to test, like a patient who's hypoxic with an acute severe asthma attack. You're not going to deny them oxygen and do a trial if they're hypoxic. You're just going to give them the oxygen. So their class 1 indications is where it's very, very strongly recommended. And if you don't do that, then the patient could very reasonably say, why didn't you do that? Class 2 is a bit more nuanced, and it's split into class 1A, where it should be considered, where almost everybody would say it was the right thing to do, and class 2B, where it's much more of a maybe. Class 3, on the other hand, is that do not do. It's been shown to be harmful, so we shouldn't be doing class 3 things. And then the level of evidence, level A is multiple randomized clinical trials. Level B is a single randomized clinical trial or large non-randomized studies, and level C, where there's little studies or it's expert opinion or registries, so much poorer quality of evidence. Good. So with all that in mind, let's get on with some cases. So case 1 is an 84-year-old lady, and she's seen in clinic by you with a fall, or maybe in your GP surgery. So are there any further questions you're going to want to ask that patient? So what do you ask your patient who's had a fall? Yes, have they blacked out? So patients often struggle to give you really good, clear histories, but that's the number one question is, do they remember hitting the floor? Did they pass out? Good. Anything else? Very good. So prodromal symptoms, those are probably the two best questions to be asking. Did they lose consciousness? Was there a prodrome? Um, and then next up, yes, what were they doing at the time of the fall? Very good. So there are lots and lots of questions, and I think you're getting very much what I'm looking for. So there are a few here. If you look on the YouTube channel, there's a presentation on blackouts, which goes over all of this in a lot more detail than I'm going to go through here. But we want to know things like, did they lose consciousness? How long did the episode last for? How often are the episodes happening? The prodrome of any warning features and aura, anything that might give you a clue as to the diagnosis is very, very important. Palpitations, generally speaking, I don't find to be enormously helpful, but it is worth checking with the patient if they're aware of palpitations. And specific to things like pacemakers, not specific, but important questions with regards to pacemakers are: is it affected by neck movements? And that could be craning backwards. That would be vertebrobasilar insufficiency. That's exceptionally rare. I've never come across that, but maybe the care of the elderly people in the audience may feel that they have seen that. And carotid sinus sensitivity, hypersensitivity would be brought on by neck movements. Obviously, change in posture is very important to help diagnose something like postural hypotension. What other specific questions, if moving beyond the history, by all means, if you think I've missed out a key history question, type it in, but what other key questions will you be, or things will you be looking at for this patient you're seeing with a fall? Yeah, so I would be including that in my sort of frequency. But knowing something about a history of falls is important, and knowing what their past medical history, certainly that would be, there are important things in the past medical history. Anything else? So if they had a past medical history of myocardial infarction and severe left ventricular systolic impairment, that's going to make you think very differently about the patient who's presenting to you with the fall. But what about medications? Are there any medications that you're going to be looking at? Yeah, blood thinners. Patients have to be falling frequently and injuring themselves to be wanting to think about stopping blood thinners if they've got a high CHA2DS2-VASc score. So just a one-off fall, particularly if it's postural hypotension and they're able to control it, wouldn't. But you're right to be aware of blood thinners. Anti-hypertensives, yes. Vasodilating drugs, particularly. So amlodipine, isoruron nitrate in combination used to treat angina might be started when the patient's 70 and then not be reviewed over the next 15 years. And as they get older, they get more sensitive to these things. Their arteries get stiffer. And so it then can lead to them having falls. Beta blockers, very much so, rate limiting medications that might be causing heart block. And what is the classic thing that you should check if you're doing an MRCP or you're in an exam situation? What classic drug do patients who come in with blackouts take? So it's, if you're not typing it, it's timolol eye drops. So eye drops with beta blockers in them can be absorbed into the circulation and cause heart block. And I have only ever seen that once, and I decided to put a pacemaker in that patient anyway, because I did feel that if they're that sensitive to such a tiny dose of beta blocker, then the chances are, if they're, even if their complete heart block resolves, that, well, did it definitely resolve because of stopping the timoral eye drops, or was it just that it spontaneously happened to, it's often intermittent, and can I be absolutely sure that their heart isn't going to stop? So I put in a pacemaker for safety, and they did end up using it a lot. So don't forget to check the eye drops if you're in an exam, and also ask about family history. So nobody's mentioned family history yet, so that's important. Perhaps not in an 84-year-old coming in with a fall. It's a bit late for family history of sudden cardiac death to be hugely helpful, but in a younger patient, that would be very important. So we want to then examine the patient and check things like lying, standing blood pressure. We want to do check for carotid bruits, and that's more because we might want to arrange for carotid sinus massage than because you're going to do it yourself. It used to be that you'd just do that on the ward or even in clinic, but there is a danger that patients become very bradycardic indeed, or have a stroke when you do a carotid sinus massage. So I wouldn't be recommending that you do that now for carotid sinus hypersensitivity in an 84-year-old patient, whether or not they've got a bruit. We could argue how useful a bruit was at telling if a patient was going to have a stroke with carotid sinus massage, but that's still what we do as a standard. We would want to do a full neurological examination and think about things like vertigo as a potential cause of symptoms. And that might not necessarily mean you doing these tests, but it's thinking about if they're necessary, and maybe getting a physiotherapist to help you. Loads of blood tests that we might do. We won't go into those right now, but can anybody throw me up a differential diagnosis of falls? So there are loads of different reasons why people fall. And I obviously get very excited about the cardiac ones because I get to put in a pacemaker, but what about the others? So vasovagal syncope, absolutely very, very common. Parkinson's, so yes, absolutely, but just why does Parkinson's disease make you fall? So you covered a number of different reasons for falling in the one condition. So yes, the shuffling gait, but it's also the slow reaction time that you have with Parkinson's disease. That's probably a bigger factor than just the gait, isn't it? Because they don't catch themselves when they lose their balance. Yes, cardiac syncope. So when we say cardiac syncope, what we mean is a Stokes-Adams attack. Cardiac syncope is one of those slightly funny terms because syncope is, just blackout due to loss of blood supply to the brain, and that happens with vasovagal syncope, which is kind of a form of cardiac syncope. But when we say cardiac syncope, we mean a bradyarrhythmia or a tachyarrhythmia. We don't mean that. So a Stokes-Adams attack where you fall flat on your face and break your nose, you don't put your hands out to stop you. That makes you think of a bradyarrhythmia. Good. So lots and lots of differentials that we need to be thinking about when we see the patient. Thank you very much. So if we have our 84-year-old and they've got a history of a blackout, and that blackout occurred with a bit of warning while they were standing, and this is their ECG. Do you think that, what does this ECG show, and do you think that they should have a pacemaker? Yeah, it's first degree heart block. And does this buy them a pacemaker? No, it doesn't. Very good. This is quite marked first degree heart block. I showed you, if you watch the bradyarrhythmias presentation, I show you some exceptionally prolonged first-degree heart block. And there's obviously a gradation in this. And I would be a bit nervous about this patient. I would be thinking about doing a 24-hour ECG in order to see do they have high degrees of block at other times. But the fall that they've had doesn't fit with this first-degree heart block as a cause, because it's not got a Stokes-Adams attack flavor to it. So they don't require a pacemaker on that basis. If they had a very classic presentation, I'd have a hard time with this ECG because it is a long enough first-degree heart block that it makes me nervous. But certainly, according to the evidence base, it's not indicated. And it's worth being clear that patients that have blackouts should not have pacemakers just because they've had blackouts, unless there's also evidence of conduction disturbance or bradycardia. So it's a class 3 harmful to put in a pacemaker for a blackout. And number of patients that I see who've got non-cardiac or non-Stokes-Adams type attack blackouts who get pacemakers recommended to them, and they invariably have something abnormal about their ECG. It can become very, very hard to change the direction of travel. It can be very hard if somebody said put a pacemaker in for me to change that, because I'm going to get it wrong both ways. If something bad happens, if I put the pacemaker in and something goes wrong, then I've caused harm doing that, and I didn't have a strong indication to do it. If I don't put the pacemaker in, and then in a year's time, the patient, because they tend to be frail and elderly with an abnormal ECG, goes on to have a Stokes-Adams attack, then if only they'd put the pacemaker in that was recommended by the other doctor, that might have not have happened. They might not have fallen and broken their hip. So we do have to be very careful about recommending pacemakers when we're not following the guidance, because it's very hard to change plans, and it's very damaging for patients when doctors say different things. What about this ECG? So this ECG, again, does anybody want to tell me what it shows? Yep, there's right bundle branch block, very good. So we've got little r, s, big R, RSR pattern, or an M shape in V1. It's lopsided. The first little R wave is small. This is typical right bundle branch block. We've got an S wave in V6. You can try and make that into a W if you like. Anything else? So the other thing to say is, can you see that it's negative in 2 and 3? So this has also got left axis deviation. So this is bifascicular block. So they're living off one fascicle. Does this patient who's had a dizzy spell and blacked out moments after having the dizzy spell, do they need a pacemaker? Ooh, so we've got a yes. Anybody else? So this is definite signs of conduction tissue disease. So right bundle branch block or left bundle branch block, or we've got bifascicular, trifascicular block, all of those get lumped together. And that together with unexplained syncope, and the history is rarely absolute. What I'm presenting is probably realistic. If it's a true cardiac syncope, I really would not expect warning, but the patients haven't necessarily read the textbook, and that together with this ECG would be enough to justify putting in a pacemaker. And that would be a class 2B. So that we could argue about it, and it wouldn't be wrong if I decided not to. It wouldn't be right if somebody else decided to do it. We shouldn't be doing lots of 2Bs. It very much comes down to how strong we think the history is. So it helps to guide us one way or the other. If the patient was asymptomatic, they absolutely should not end up with a pacemaker. That would be harmful because there are risks of complications with pacemaker implant. There's an entire talk on complications and consent, actually, because consent is quite an interesting concept to dig into, and what is a complication on the YouTube channel if you want to watch that. So asymptomatic bundle branch block does not get a pacemaker. And this is very much the kind of patient that I'm talking about, where if they have a history that is really good for non-Stokes-Adams attack, non-arrhythmic syncope, that I'm not going to help with the pacemaker, but they've been offered a pacemaker and admitted to have one from the admissions unit, that puts us in a really difficult position trying to change the direction of travel. I had a patient who passed out while sitting in a car on a hot day in the middle of summer, and it had a very clear prodrome of feeling very lightheaded and unwell, followed by a blackout. But because he was sitting, it was felt that it couldn't have been a vasovagal syncope, even though the features of it were very strong and the reasons for it happening were very strong. And he had a bivesicular block on his ECG. So, what do you do in that circumstance? Well, I didn't put the pacemaker in, and I was pleased to see him well in clinic afterwards. But it is hard with these cases, particularly when patients are at risk of blacking out for, or having falls for other reasons, and you'll never know it wasn't something that a pacemaker could stop. So you can easily get things wrong either way. We talked about carotid sinus massage earlier, so think about neck movements as causing patients to black out. It's pretty rare. I have to say, I go years without putting in a pacemaker for carotid sinus hypersensitivity. So it's pretty rare, but it does certainly happen, and it can be really profound. I used to rub on people's necks in clinic while feeling their pulse at their wrist, and I certainly don't do that anymore because it's just not safe. Things have changed a lot, and this kind of thing, this long pause, certainly we wonder about putting on a pacemaker. So what do you think? Do you think we should put a pacemaker in for this long pause? It's always a difficult question putting in a pacemaker in a young person. This is not going to make the heart stop. This sort of long pause is going to be very unpleasant for the patient, but it's not likely at all that the heart is not going to restart. It's just going to take a long time to do so. But if this is causing syncope, it is a class 1 indication for a pacemaker, although the evidence base for it is not so good. The difficulty with putting in a pacemaker here is that they very often drop their blood pressure as well as going bradycardic, and it's no good having blood pressure of 50 systolic and a heart rate of 100. It's not going to mean that you don't feel dreadful, but it may stop you from passing out. So I don't promise that I'm going to fix the symptoms, but I may help the situation. So this is an example of something that we see infrequently. This is probably a few times a year. And this is a loop recorder, which has been implanted for a patient that might have syncope once a year and going back for a long while. And they often have vague symptoms of abdominal pain or just something's not quite right, and then they pass out. And so this loop recorder might have seen absolutely nothing, absolutely not a sausage of any heart rhythm disturbance for the first year that it's been in, or even longer, and then suddenly it does this. And can you see that this is asystole and there are no P waves present? So this is not a heart block. This is the sinus node has stopped. Would you put a pacemaker in for this? Well, the answer to that is yes. It's a two-way indication, but again, not a lot of information, and particularly in younger people, it's a hard judgment to make because of the long-term negative impact of having a pacemaker in. Over a very long period of time, the pacemaker risks getting infected, the leads will break, they'll need more leads putting in. Removing infected pacemakers carries a risk of tearing something serious inside the body, so there's a risk of mortality with a extraction of a pacemaker that's been in a long time. So we do need to think carefully about it, and it depends a bit on whether it's causing unpredictable recurrent syncopal episodes. Again, the heart isn't going to stop. There's no heart block here. It's not going to stop and not restart, but it obviously can cause a great deal of inconvenience, and we do feel a bit nervous saying it's not going to not restart. So that does get a device. So the duration of the pause is important, and the symptoms associated with it. If you had, well, I'll come on to that in a minute, actually. So we'll cover that in a moment. And also, sure, the frequency of pauses. I'll talk more about those in a moment. But this is, rather than just being a short pause, is not usually associated with this. We call this reflex asystolic syncope. So short pauses are much more common and are probably a different mechanism. There are patients who have tilt table induced cardioinhibitory syncope. And can you see this is the systolic blood pressure along here? This is the heart rate along here. I don't know if you've ever watched a tilt table test. I have supervised more than I care to remember. They involve having a patient lying flat for about 20 minutes, and then we tilt them for about 20 minutes. And assuming they're not lost consciousness during that time, we give them a squirt of GTN under their tongue, and then they black out. They can be very useful, but they're not a test to request frequently. They need to have very specific circumstances. And during a tilt table test, patients can drop their blood pressure, or they can drop their heart rate. And very often they do both. And much like carotid sinus hypersensitivity, the question is a pacemaker going to help this sort of a condition? So these are patients who suddenly drop their heart rate and their blood pressure, usually when they're standing up. And again, a pacemaker can help prevent this with a class 2B indication. So we're going to talk about pauses, and we'll come on to that in a minute. Before we get there, I'd like to present another patient, and this time we're going to talk about a 50-year-old man who is completely asymptomatic. So 50-year-old in good health, no major past medical history, who is completely free of symptoms and just gets incidentally found to have an abnormal ECG, which looks like this. So what do you think of that ECG? Does that need anything? What's the underlying heart rhythm here? It really helps to mark out P waves and QRS complexes on 12-lead ECGs. This is the sort of ECG I find people struggle with a lot, and they often think, is this complete heart block? In complete heart block, you expect there to be regular ventricular activity, and you can see the ventricular activity here is not regular. So that means that you can rapidly say this is not likely to be complete heart block unless these were a ventriculectomy, which clearly they're not because the morphology is the same. So this is indeed Mobitz type 1, very good. We have PR interval which prolongs and then is dropped. The P wave is in here. It resets, prolongs, and is dropped. You can see a P wave at the end of the T wave over here, and so on and so forth. So this is Venki-Bach. And does Venki-Bach type 1 second degree heart block type Mobitz type 1 heart block require a pacemaker? Well, the answer that has historically always been the case is no, and I'm sure that's what exams are still looking for. But actually, it's a 2A indication depending upon where the level of the block is. So you can actually do an EP study and find out exactly why this is happening. And if we had a young athlete who was having this during sleep, then absolutely it doesn't require any further consideration, and it's normal, very normal finding, expected finding even. But if we have an 80-year-old who's got this ECG at rest, it's a very abnormal finding and almost certainly does need a pacemaker, and you could do a heart monitor to confirm high degrees of AV block. In our 54-year-old, we would need to take a bit more of a history, and if he was an elite cyclist, then maybe I could let this pass. But I would be nervous about this sort of ECG seen at rest, as opposed to a little bit of this during the middle of the night on a 24-hour ECG. How about this ECG? It's not the best quality ECG. It's got left bundle branch block very good. Can you see how you can't really see the P waves very well in lead 2? Which lead should you go to if you can't see the P waves very well in lead 2? Well, the answer is lead V1 very often has good P waves if lead 2 doesn't. So can you see here, there's a P wave here, a P wave here, a P wave here. So we have 2 P waves to each QRS. So we have Mobitz type 2 heart block. Once you identified this as being a P wave, you can look down and see actually this is a P wave. It just was hard to work out what was P wave and T wave before, but this is definitely a P wave, and you can trace it all the way along the ECG. So that's Mobitz type 2 and left bundle branch block. And if that's asymptomatic, does that buy the patient a pacemaker? So what if this is asymptomatic and rather than this being his ECG, it's the middle of the night on a 24-hour ECG and he has 2 beats of this. So just 2 beats, a moment's 5 seconds worth of 2-to-1 heart block in the middle of the night. And he doesn't like the idea of a pacemaker. Does he still need one? So the answer is yes, he does. If it was just that very little bit as a one-off, then I wouldn't admit the patient. I'd do it as an urgent outpatient. But if I happened upon a patient in pre-admissions clinic or GP surgery who had this as their resting ECG, I would admit this because of the risk of falls or blackouts or even death. As soon as there is clear evidence of AV block, there is a risk that the patient dies of that arrhythmia. So the difference is the P wave is not conducted. That is AV block, as opposed to the sinus node stops working and you don't get any activity because the sinus node stopped working. And this ECG, so look at the P waves. You see there's a P wave here buried in the QRS. There's another P wave here in this T wave, changing the morphology of it. Look how different that T wave is from that one. So we have a fast regular sinus rhythm or atrial rhythm and a regular slow ventricular rhythm. So absolutely, this is complete heart block. And again, it needs a pacemaker. And this one I think we've talked about before a few times. This is a really important ECG not to miss. This is, can you see the irregular baseline? This is atrial fibrillation. But importantly, we have a regular ventricular rhythm. And if you've got a chaos of noise going on in the atrium, shouting at the AV node to beat, it will never end up beating in a regular manner. So the only thing that gives you a regular ventricular rhythm in AF is complete heart block when you're not listening to the atrial fibrillation. So really important not to miss that, because this patient is every bit at risk, as high risk as the previous patient in sinus rhythm and complete heart block, or with sinus activity and complete heart block. So this is a class 1 indication, but evidence is very weak because nobody's going to test if this is a good idea or not, because the patient wouldn't live without it. Of course, if it's reversible, so this is due to high doses of beta blockers, then that doesn't require pacing. That would be a level 3 indication if we can fix it in other ways, but we need to be sure we can fix it in other ways. So I was asked earlier about a pause. So this asymptomatic patient has a 24-hour ECG and he has a pause on his ECG. Now, I've not given you the squares to tell you how long this pause is, guessing it's probably about 3 seconds or so. Can anybody tell me how long a pause has to be to buy you a pacemaker? And just to be clear, this is not heart block. This is a pause. Can you see P wave, QRS, no P wave, no QRS. So if there was a P wave and no QRS, that would be heart block. That would get the patient a pacemaker. So 5 seconds, yeah, 5 seconds is a good figure. Over 3 seconds during the day, very good. So we tend to work on 5 seconds nocturnal pauses and 3 seconds during the day. The ESC guidelines talk about 6 seconds, but you know, I think we can argue about that, and it basically comes to the same thing. It's not really a different guideline. So asymptomatic pauses do need a pacemaker, and here it does matter how many the patient is having, because remember, your ECG or your 24-hour ECG is only a small snapshot of what's going on with the patient. You don't want to miss what's going on the rest of the time. So if they're having 30 2.5-second pauses during the day, I'm not going to deny the patient a pacemaker just because it's not quite over 3 seconds. And you know, you can see them happening quite frequently sometimes in patients. You might think about, if this is happening at night, something like complete something like obstructive sleep apnea, which can sometimes do it. This ECG shows something quite interesting, which I'm starting to run out of time, so I would love to give you lots of time to try and work it out. But this shows how atrial fibrillation can cause syncope. It doesn't do it by going fast. It does it because when you cardiovert to sinus rhythm, it takes a long time for the sinus node that's been asleep in atrial fibrillation to wake up. So here it doesn't take very long, but on this occasion it takes it about that's about 6 seconds before the sinus node finally wakes up, and then you go straight back into atrial fibrillation again, and the same thing happens, and it happens a number of times. So this is, we call it termination syncope. When the atrial fibrillation terminates, it takes a while for the sinus node to wake up and the patient can black out. So this might need a pacemaker. What about a patient who's got a sinus bradycardia and exertional breathlessness? Does that need a pacemaker? How do we work that out? Yeah, absolutely look for reversible causes and review the meds. So hypothyroidism, beta blockers, calcium channel blockers. So very important to look for potential causes of this. Assuming you rule all of that out, does it need a pacemaker? It's very hard to know what the right resting heart rate for a patient is. A good start is to do a 24-hour ECG and look for rare variability in that, get them to do some exercise while the 24-hour ECG is on and see if their heart rate increases appropriately. If it does, then probably it won't help. We could get them to do an exercise test if we're still unsure after doing that. But ultimately, sometimes we don't know until we put a pacemaker in, by which time it's too late if that's causing their symptoms, or if it doesn't fix their symptoms. But if they can clearly have their symptoms attributed to bradycardia, that is a class 1 indication. If they can't, then that would be a 2B. So that would be a kind of probably don't do it if they just have a sinus bradycardia and it's not causing symptoms. And you do see patients with heart rates of 40 that can't be explained who feel perfectly well. And so you do end up scratching your head and feeling a bit uncomfortable about it. And obviously, as you've said, we need to exclude reversible causes. So case 4. Sorry, excuse me while I sneeze. So case 4, we've got a 55-year-old man, and he has had a previous myocardial infarction and has severe left ventricular systolic impairment and left bundle branch block. So would you think about a device for this patient? Imagine that his ECG looks like this. So we have a 55-year-old patient with a previous myocardial infarction. So what device would we think about for this patient? We know that patients with weak hearts often have dyssynchrony in their ventricle. So that means that one side of the ventricle starts to contract before the other. And so it doesn't coordinate, it sort of wobbles rather than the apex of the heart rocks rather than it contracting in a normal twisting, squeezing motion. And the best way of assessing that is actually still to look at a 12-lead ECG and look how broad the QRS is and whether it's left bundle or not. And patients with a left bundle branch block benefit, patients with right bundle branch block probably don't. And the wider, the broader the QRS is here, it's about 160 milliseconds, the more benefit. So we'd be looking at a biventricular pacemaker or defibrillator. And here the patient's 55 and has had a previous MI, so we'd be thinking about a defibrillator. And we would call that primary prevention. So we're putting in an ICD before they have sudden cardiac death. DVLA calls that a prophylactic pacemaker, or prophylactic ICD rather, and that's an important term because it really confuses patients. And if they have a primary prevention ICD, they can't drive for a month. If they have a secondary prevention ICD, they can't drive for 6 months to 2 years. So it's really important that we get that right on discharge letters and what the DVLA guidance is for the ICD. This is the NICE guidance on use of ICDs. It's rather out of date, 2014 that came out, but this is still what we use. Actually, the situation hasn't changed that much in that time. So it's a little bit complicated based on the QRS, and they don't specify beyond just saying high risk. So we can have a lot of flexibility to decide what we want to do. So some patients would say that dilated cardiomyopathy is lower risk and doesn't need an ICD. Having a scar from a previous myocardial infarction makes you higher risk and probably does count as a risk marker. There are loads and loads of different risk markers for sudden cardiac death. Enough for many, many PhDs. If any of you are interested, I do a lot of research into this, but it's an intrinsically very difficult to predict who's going to have a ventricular arrhythmia. And this sort of a patient probably stands a risk of about 1 in 20 a year. And there is a balance, therefore, between the risk of the device implant and the risk of it happening. But here, with the left bundle branch block, I can make him live longer by putting in a biventricular device. So I'd put in the ICD with it. There's no age cutoff, as you can see. Interestingly, gender has an effect. You benefit more from biventricular pacing if you're a woman and less from an ICD, but that's not mentioned anywhere because that's quite a politically difficult thing to say. If this patient had had a VF arrest and had successful resuscitation, we would put in an ICD, even if he's only got mild impairment or she's got mild LV impairment. So well, once the episode's happened, LV ejection fraction is a very bad predictor of is it going to happen, but the problem is nothing is better, and we have to have some sort of gatekeeper. So secondary prevention ICDs go in if they've got a non-preventable cause of ventricular fibrillation. The last few minutes, I just want to show you a chest X-ray and tell you a little bit about what putting a biventricular pacemaker in involves. So look at this chest X-ray and tell me what device this patient has. So you can see that there are multiple wires and none of them go to the atrium. And the reason none of them go to the atrium is that the patient's in persistent atrial fibrillation. As soon as you've got, this is a left ventricular lead with those 4 poles I showed you right at the start, we would always have a lead in the atrium unless they were in persistent permanent atrial fibrillation. And you can see there are 2 leads in the ventricle, and that's because one lead has failed long ago and they've had to have a replacement lead put in. Now, can you see how clear this thick defibrillated coil is on the leads? You have the shape of the lead, or the appearance of the leads is uniform, and then suddenly this thick coil. If this was a pacemaker lead, it would look like the uniform bit all the way to the end. You'd see this pole and the tip right at the very end. So you could immediately say this is an ICD lead, and we only tend to put one in the ventricle these days. The original ICD lead has got a coil in the superior vena cava as well, but we only tend to put them in the ventricle now because that works well enough and it's easier to extract them. So this is a biventricular device. This is quite an interesting X-ray because you can see here this is a calcified left ventricular aneurysm. This patient's had a previous big anterior MI. There's very clear evidence that patients live longer and feel better with biventricular pacing and with ICDs. How do we put them in? Well, we use an X-ray camera. We point it at various angles at the patient. And we're aiming to put a catheter into the heart and into the coronary sinus. And then we feed a wire down the coronary sinus and then a lead over the wire. And we're trying to get the left ventricular lead as far away from the pacemaker lead in the right ventricle as possible. And so the right ventricle is in front of the left, and we want to put it towards the back, over on the lateral side. And the problem can be, do veins go the right way? So if I want to get it down this vein, is there a vein there? Because the venous anatomy is very, very variable. It wouldn't be any good to put it round here and be quite close to pacing the right atrium and certainly a long way from the bit that it is going to resynchronize the heart. And so what does that look like in practice? Here we've got our catheter in the coronary sinus. Balloon is inflated to allow us to inject dye down. This is blocked here because he's had the big anterior MI, but we can see this lateral branch that we put the lead down through. So we've had to feed the lead all the way around there. So really tricky procedure. We can't get that in about 1 in 20 cases, but it can be really beneficial for symptoms. So thank you very much for listening. Are there any questions at all? This is some quick summary points. Just remember that taking a good history with patients with blackouts is absolutely essential because it really does very much rest on what your history of the fall is. Was it a blackout? Was it sudden? Remember red flag signs. So things like family history, things like exertional syncope, very important. Pacemakers are a low-risk procedure, but it's very important to try and all be on the same page when it comes to recommending devices to patients, and we shouldn't put them in without good cause. And in your patients, if you go out from cardiology and you've got somebody who's got severe LV systolic impairment, we should be thinking about an ICD for that patient, along with excellent other medications. It's very important that if they've got heart failure, we do lots for them rather than just think about a device. Thank you very much for listening.